games in London, and then maybe we talked about this the other day, but we got a pretty tough schedule. These after London, those next 4 games are going to be pretty tough. But if we can pull maybe 1 or 2 wins out, either
Yeah, like I
between,
said, if you can go 500 in England, the Jags have a
well, it'll
shot
put us what? It'll put us at 3 and 4.
before you come back with that
Yeah,
nasty stretch.
yeah,
So, all right.
we'll see.
But talking about nasty stretches kind of leads us right into what we're talking about here today. So do you want to do the intro and then we'll jump right in, or you
Yeah,
want to just jump right in?
we'll do it just a quick intro. I appreciate everybody joining in today. If you didn't catch last week's webinar, I'm going to post a link in chat. It was a pretty good subject that our guest Tracy, actually, who's here today, gave us the inspiration. We talked
Yep.
about record keeping essentials, and it actually was a really good turnout, Tracy. I appreciate it. And um, unfortunately, I know you couldn't make it, but if you want to hit the recap, it's in here in chat. But other than that, I think it's safe to say, well, Tracy's been to several of these webinars at this point, but for those of you that may be joining us for the first time, my name is Ray Walters. I will be your host for today's session. I'm joined by my co-host, Jose Delgado Jr., who has 17 plus years in healthcare consulting, currently owns a mental telehealth clinic. And yeah, today's subject, very interesting.
It's all about leverage. It's all about
Yes.
leverage. I mean, that's really what that if we were to TLDR this and you want a 30 seconds, when dealing with insurances, it's all about leverage.
Yeah, and
So I've actually
just to give the audience just a quick overview of today's topic, and this is recently a local healthcare system here, Baptist Health, was going through a high stakes negotiation with Florida Blue. The deal it was not looking good. And I think
no.
they finally struck something at like the 11th hour of the deadline.
It was literally
and
like 12:30 after the deadline had
Yeah,
expired. So it
very,
was
very last second. But I mean, the main dispute was reimbursement rates for Baptist Health from Florida Blue. Baptist was seeking to increase rates to align with other healthcare systems here in Florida, which I believe in Tampa, they're in comparison to Tampa and Orlando area. And some members that were impacted, I think, through this deal was
oh,
Medicare Advantage
so
members, and
yeah,
good.
yeah. So it was anybody who had a Florida Blue product was affected by this. The
Right.
only people that were truly would have felt the effect and still are going to feel the effects going forwards are those that live in the Northeast Florida area where Baptist is has a very, very strong presence in the area. So if you're not familiar with Northeast Florida, Baptist Health is the largest hospital system in Northeast Florida. They have hospitals all over the place, surgery centers, urgent cares, primary cares, imaging lab. They are a complete healthcare system, and they're the largest in Northeast Florida. And as well, Northeast Florida happens to be the home of Florida Blue,
Mhm.
and thus Florida Blue in Northeast Florida is the premier and most widespread health insurance. So really today is about what we wanted to talk about was basically we want to discuss leverage,
Yep.
right? So the deal, the way that it turns, what the hospital wanted was they wanted higher rates. Duh. Right? What the insurance wanted was not to give higher rates. Duh. Where was the leverage that Baptist Health had? Baptist Health has the only pediatric hospital that I'm
Yes.
aware of in North Florida,
Which
east of
is
Tallahassee to the Atlantic, and south all the way out to Daytona.
I
I
know
mean, I think Shands has a pediatrics hospital in Gainesville, but that's
here in
Gainesville.
Jacksonville, it's Wolfson's. That was
Yeah, it's
yeah.
Wolfson's in Jacksonville, right? So, but that's the only pediatric hospital. So, obviously, Baptist Health has that. Because if you're unfamiliar with how insurances work, I'm going to give you the 3 minutes on that one because there's a lot we got to cover, right? An insurance works and has certain rules that they have to run by. Think of them like a casino. Okay. They have to have a certain amount of cash on hand for every single policy that they have in case that there's an emergency like a hurricane or a bomb or anything like that, where some major event where they have to cover a lot of cases all at the same time. On top of that, especially after the PPACA, there's a thing called a narrow network where they have to have a certain amount of providers of certain types in a certain geographical area from where the patient lives. So if the patients are unable to get that access, they can be considered a narrow network. They can get kicked off of exchanges. They can get lower star ratings if they're a Medicare Advantage plan. They can get paid out less from the federal government's other programs. It makes their program in general look bad because then you have patients that are complaining and it becomes a whole thing. So really what the insurances try to do is they try to partner with large groups and say, hey, if you can handle all of this, we will quote unquote funnel all of our patients to you. This is where pharmacy benefit managers come into play. This is where you see deals with insurances and certain pharmacies happening. Like I always blank on this. I want to say it's Humana and CVS, where Humana pushes all of their pharmacy through CVS. And then I want to say Walgreens has another one. Walgreens is Aetna or Cigna, something like that. But basically, you can just take a look, and a lot of these pharmacies have deals with certain insurances, and the insurances will streamline all the patients there. Now, the patients don't have to go to these places, but now we're talking about in network versus outer network. And I don't want to get into the PPO, HMO, garbage right now because there's so many PPOs that are operating like HMOs nowadays that it's not even worth it. But going back to the deal that Florida Blue was saying was, hey, everything with Wolfson's will give you a higher rate and everything else will kind of keep where it's at. Well, Baptist is claiming, like every other hospital in the US, no, we have higher costs, we have higher this, we have higher that, therefore you must pay us more, and or else. And the or else is we will pull, when you kick us out, we will take Wolfson's with us. And for Florida Blue, that doesn't work because this affects all of the Florida Blue plans. This affects all of the employer plans that are also using the Florida Blue network. So this affects not just
for both parties.
It's
really
massive. So if you have a larger company, because of the prevalence of Florida Blue in Northeast Florida, you're looking at a situation where all of a sudden you're an employer. You don't know what's going on until one of your employees says, hey, my kid needs to go see the doctor or a specialist, but now he can't because for some reason the plan isn't being accepted there. So you can see how this kind of snowballs really fast and makes Florida Blue look like crap by Baptist saying, hey, bite me. Now, they figured out a deal, but the deal hosed a percentage of the Florida Blue clientele, and there's a transition period until Halloween. So if you're a Florida Blue client, you need to figure out if this affects your plan. So if you're an Obamacare plan, so if you're from the exchanges, if you're a Medicare, one of the Florida Blue Medicare Advantage plans, which anyways, you need to be aware of that as well. And also the self-employed, not the self-employed, the self-funded employer plans. So if you're using the Florida Blue network, but you're an organization that's technically self-funded, you may have a problem, which is going to be very interesting because some of those organizations are St. Johns County. Everything is Florida Blue.
Yep.
So that's going to be a giant problem. St. Johns County is the county just south of Duval. there is a hospital in St. Johns County, and they have a major primary care and urgent care all on the north end. And I believe they're expanding in the western end of the county as well. So this becomes a very, very large problem for them. But that's a problem for another day. We bring this up as a topic, though, because if the hospitals are, is Florida like, yes. So
Yes.
Tracy, think about it like this. Florida Blue Cross Blue Shield is a franchise. Every state has its own Blue Cross Blue Shield, and they just call it something slightly different. I want to say, someone correct me if I'm wrong, but New York's is like Empire Blue or something like that. Everybody's got a different Blue Cross name for every single state because it's all it. They're each state has its own little franchise. They also tend to be Medicare fiscal intermediaries because they already do all the things for insurances, but that's technically another bag of tricks. So basically, what you're looking at is they are, if the hospitals are starting to play hardball with the insurances, whereas before they were best friends. What does that mean for smaller organizations, even medium-sized organizations? It means that we need to start leveraging as well. If you haven't started leveraging, you need to start leveraging. Now it becomes tricky and it becomes scary because why? If I'm a practice that is less than 10 years old, I would say, doesn't really matter because you just started being profitable and figuring things out. So switching things up is not a big deal. But if you have a provider that that is a baby boomer, late Gen Xer, older Gen Xer, then you're looking at a situation where they've been in business probably 20, 30 years. So then trying to get them to switch and some of the legacy patients, and it becomes a tricky situation. But we have to understand we can only do so much for our patients. If we cannot pay for our overhead, we can't see our patients at all. So sometimes we have to be tough and difficult in order to save the entire organism. So I would use it as, hey, sometimes we got to chop off the foot to save the body, right? So
It's definitely a
this is
fine
where,
line.
yeah, this is a very, very fine line. But this is the perfect time of year to assess this kind of thing. One, because you can take a good look and see what your census looks like in your practice. So for example, every state's going to be a little bit different because the population demographics are very different, right? But here in Florida, if you're 30, you to have a healthy practice, you generally wanted to go and have 35% Medicare, 35% either Blue Cross if you're in Northeast Florida, or 35% Molina if you're in the Miami area. And if you're in the Tampa area, I wanted to say it was Blue Cross as well. I want to say it was Blue Cross as well, but 35%
Pretty sure
Medicare,
it
no
is.
matter what, 35% that major private insurance, and then 30% everything else. That's your cash patients, so they're self-pays, your HSAs, your United, Aetna, Cigna, all that crap. Workers' comp if it's appropriate, accidents, slip and falls, all that crap, right? So, but we need to know what your patient census looks like. If you don't know what your patient census looks like, you have a problem. Talk to your billing team, department, vendor, whatever the case may be. Number two, what is your cost? If you don't know your costs, you don't know when you're profitable. It's that simple. You need to be able to break it down to a per hour. I would even like it personally, and we do it in our practice where it's a per patient, but or per patient encounter, but that can get tricky depending on if you're in a multi-location, if you've got procedures along with office visits, that can get really funky. But you want to figure it out at the very least by the hour because providers are the most expensive thing on your payroll and they charge you by the hour. So, got to figure out what your cost is because then you can sit there and say, okay, this guy's paying me under, this guy's paying me under, this guy's paying me under, this guy's paying me under. And then you have to have the conversation. Is it worth keeping that business or is it worth transitioning those patients into cash patients or cutting those patients entirely? if you're going to make a change, this is the time of year to do it. The reason is you make the decisions now and make them effective January 1st when it doesn't bloody matter anyways, because everybody's got to pay deductibles. It's deductible season once January hits. Even Medicare's got a deductible, right? So nobody's going to escape it. I don't care if you have a secondary. It never happens. You're always going to end up paying something, right? That's just the way these insurances work. To prevent overutilization, that is the purpose behind a deductible. That is the purpose behind a copay. Miss me with the nonsense otherwise. All right. So, what are your numbers? What do you need to do to keep those doors open? Right. So, Baptist Health decided, well, we know that we have leverage with the insurance company because of Wolfson. So we're going to use the Wolfson card to get everybody else more revenue. Makes sense. Ballsy move. They kind of got what they wanted, but it kind of seems like a fair deal where, in my mind, and the reason is because both sides left unhappy. Both sides left a little bit happy.
Right.
Blue Cross got to save face. Most of their clients are covered. Baptist Health got rid of bad paying clients anyways. Your Florida Blue from the Obamacare, the exchange plans paid like crap. The Medicare Advantage paid like crap, right? So it wasn't worth it. I mean, I remember 3 years ago, if you wanted to get onto a Florida Blue onto their network, you actually had to accept their crap plans in order to get their good plans. So Baptist Health, in a stroke of luck / perhaps shrewd negotiations, were able to get rid of the bad clients. Where now they're just
who's
out
that
of
props
network.
to their legal team.
It's props to their negotiating team that knows what their numbers are, right? That are paying attention to not just the billables, but the receivables, right? Because the thing with Florida Blue was that the PPO paid above Medicare for most things. But the Obamacare plans, because they're on the exchanges, and I would love to see one exchange plan that pays at Medicare rates. I have not seen one since they came out in 2008. I have not seen one insurance plan that is sold on the exchange that pays at Medicare rates, because they always pay at Medicaid rates because that's how they make the subsidies work. It's just how the monsters. There's just no way for them to be able to pay that much because they're charging nothing. And the federal government's picking up 50% or 100% of the tab, right? So you have a situation where what is that number? So let's say, hypothetically speaking, my provider costs me $100 an hour. Just flat, that is my payroll with him. I have one RN that maybe follows him around and does stuff, and one MA that is attached to him at the hip, right? His Girl Friday, for lack of a better term. So I just add up all their payrolls and say, okay, so that 100 plus that 35 plus that $15, $18 an hour from the MA. All right, so we're looking at 153.
Right.
At a flat rate. And that's not including your fixed costs, your billing costs, your ACH costs. So basically, we're looking that if your provider is not generating rough ballpark, depending on different overheads and things like that, if he's not generating $250 an hour, you have a problem. Let's say that he's a primary care. This is a primary care office where we do some little small in-office procedures and things, but mostly we're just in-office, in and out, E&M, evaluation and management visits. It's every 15 minutes. So if you're charging every 15 minutes, you're seeing a patient every 15 minutes and you're charging them $100, you're in the gold.
Yeah.
You could, and depending on your market, if you wanted to capture more of the market, you probably could go down to that 75 a visit, which puts you underneath the cash rate of probably a lot of your competitors. And with that alone, you'll get more visits because you know how much things cost. Therefore, you know where you're profitable, and pigs get fat, hogs get slaughtered. You know what I mean? Like at some point, certain aspects of this are volume based, right? If I'm doing procedures in the office, which procedures are paying out more? What codes are paying out? What codes are not paying out? What insurances are paying out? These are things that you need to discuss with the executive team now. Because if you're going to make a decision and cut anybody, you have to do it by January 1st. If not, you miss a great window where nobody cares because everybody's paying cash anyways. That January, that Q1, where everybody's billables are out of whack, where the hospitals wait as long as they can so that way they don't have to bill the patient and it becomes a giant, well, I paid my deductible here, but I didn't, so I don't need to do that there. And it's a whole mess. What are your numbers? What insurances do you want to participate with? Anybody that's giving you crap, you need to sit down and be like, what are we doing here? What are we
Yeah,
doing?
something else to just put in perspective, just going back to the deal that was reached, it is considered a long-term agreement. It's what, a 5-year contract? Is
Yeah.
that too, but you were saying earlier, both parties walked away a little happy, walked away a little pissed. But I wonder if maybe initially Baptist benefits a lot, but in the long scheme of things, because they're in a 5-year contract, costs are going up and things always are changing. I wonder if that would benefit Florida Blues in.
So
That makes any sense.
whenever, remember this, whenever you're negotiating with an insurance company, again, you're gambling with a casino. You're making a bet that you're going to make more money than them. Why? Because if you're not making more money, then what was the point of the entire process, right? So,
The
it's not
house,
too
the
dissimilar to
house
when
always wins,
unions,
though.
uh-huh. Well, and that's where I'm going, right? So it's not too dissimilar to when unions strike, right?
Sure.
A union strike, actually, I would argue that union striking is the reason why Baptist Health had to play so hardball, but that's a whole nother bag of tricks for another day. When we look at arguing with an insurance company or negotiating with an insurance company on rates, you need to take a look at not just what's in front of you, but where you want to go and where you think the environment is moving and shifting to. Okay. I'm not saying that I'm pessimistic, but I believe that history is cyclical and people are stupid. So what
Mhm.
do I mean by that? A lot of people will allow themselves to be led by the nose until they get squashed a couple times and see a couple people around them get squashed, and then they'll be like, wait a minute, maybe I don't want to do this, right? I believe that we're at a point where we're going to revert to a healthcare system that is more akin to 1970 than 2008. And here's what I mean. Exchange plans don't work. They don't work for the patient, they don't work for the providers. All the insurance plans are more expensive every single year.
Yep.
They cover less and they charge more. There's less people in the network. There are ghost networks all over the place. And if you're not familiar with that term, a ghost network is when you look up the network for a specific insurance plan and it looks
That's
robust. But in reality, the insurance company hasn't gone through the bloody trouble of confirming who is even still in business, much less accepting new patients. Because it's one thing for me to accept a product, it's another thing for me to accept new patients from that product.
right.
Right. So if I'm sitting here and I'm saying, hey, I believe that people are going to revert to cash more than insurance over the next 5, 10 years. I believe that catastrophic plans are going to make a comeback. And what a catastrophic health insurance plan is, these are the original health insurance plans right around when Medicare came out. Please remember that major medical did not come out until the late 80s, early 90s. Before that, health insurance didn't exist outside of Medicare. Everybody paid cash. You had a catastrophic plan for when shit happens, but that's it. So it's not that crazy of a concept. Our grandparents, if your grandparents are still around and they're lucid, they probably remember a good portion of their adult life where they had no insurance.
Mhm.
We are going to end up reverting back to that between all of the onerous regulations on paperwork and all the nonsense in regards to getting paid and the arguments with the insurance companies over, look, we signed your stupid insurance, we signed your stupid contract that you were going to pay us this rate, but why am I fighting you every 90 days for this? It's exhausting, it's annoying. What's the point? Right? So I'll tell you right now, this year in our mental health practice, we cut every insurance company except for Medicare. And we told all of our insurances, we're done. We're done with this. You are not helping the patients and you're not helping us. So what's the point? We figured out what our numbers were. We end up coming in a little bit above most people's copay rates, but it is what it is. I'd rather see, I'd rather have 30 patient encounters a day that I'm getting paid quickly and smoothly, and I know how much money is coming in, than having 70 on the books and never getting paid for 25 of them, or getting paid peanuts because the only thing I got paid was the copay from the patient.
I would just
It
say my
makes my
argument
encounters.
is to your point. If we reverted back to that, uh, does anybody have cash on hand these days?
Well, I mean, so okay, so but then it would be basically my credit card processor. Okay,
I
I
know.
apologize,
I'm
Ray.
messing with you. I'm messing with you. But
Freaking Gen Zer. You're a Gen Zer, aren't you?
no, I'm a millennial, my friend.
Are you a millennial? You're a baby millennial. I don't want to
I'm a
own you on this.
92. 92er.
Oh, okay, all right. So yeah, so I mean, it's something where this is all about finding what that leverage point is, right? So if you're in a specialty that you know there isn't much of, you have more leverage than other people. Take a look at what codes you use and see what you can do. If they tell you pound sand, then tell them back at you, bud. Let's see how this goes. This is where this is
Don't get
where
squashed. There you go.
huh?
I said don't get squashed. You know, I just one take from the, this deal that was made is, Baptist didn't back down, don't back
Well, not
down.
only that, but this is where growth in numbers and having an MSO or
Mhm.
having being part of an ACO or being part of an organization that is all taking a stand. Where before you couldn't do that legally 20 years ago, now it's a little bit smoother and you can get away with it in different ways. Um, you can get that leverage point, right? And it
Right.
really is funny how you only need to have a certain amount of lives in a geographical area. And I say a certain amount, like 2 or 3 thousand lives. That's really all you need. And all of a sudden, for a certain specialty in the area, the insurance will be like, hold on, all right, wait a minute. We maybe we need to talk to this guy a little bit more. In other cases, they'll call your bluff. And then you tell them, all right, cool. Well then kick us off your rolls. We're gonna inform your patients that we're done in 90 days. And let's see how it goes. They got a problem, they're going to you. And that's that. You
Yeah.
know what I mean? Like the
Yeah.
only one that you really can't do that with is Medicare for a lot of specialties. Um, Tracy, you're right. Certain specialties out of network pay better than in network, but this is that whole PPO versus HMO mess. And God, it used to be so simple, but now because HMOs are literally equal to garbage in most people's eyes because of the way that they're structured, they've changed the name to a PPO, but really it operates like an HMO. So then you're sitting here like, all right, is this a duck? Well, it has feathers like a duck, its wings like a duck, and has a beak like a duck. I'm going to call it a duck. You know what I mean? Like I'm a simple guy in that respect. It's got me into trouble a little bit here and there, obviously. My wife, especially. Whew. but she hasn't divorced me yet, so we're good there. So, but yeah, I mean, you just got to take a look. It's all about leverage. This is where you have these MSOs, these equity companies, these private equity companies, they come in and they say, hey, we're going to get 20,000 lives together over five states, 31 offices, and now they have leverage and they can negotiate these stupid, stupid contracts. where they're getting paid above Medicare rates, and you're just like, they're offering a crap service compared to what I do here. Well, the problem is that you care more and you don't have the width. So then it becomes a situation where I don't need though 20,000 lives from one insurance carrier. So then I am essentially in a, how can I put this? A bad romance, a
Right.
toxic relationship. Because we have a client that 20,000 patients. And with some of the new guard at the insurance company, they are hated. With some of the old guard, they're loved, but they're stuck in a political game. And it really screws things up. And as things progress to a full risk, it makes even less sense for anybody to be part of that unless you can control your variables. Full risk makes perfect sense if you can control a lot of the variables of the population that you have. But if you have a traditionally non-compliant population, along with a very poor and unhealthy population, you need to reassess.
Yeah.
Full risk may not be the move for you. You know what I mean? Like, so this is where, again, this is all contracting, this is all negotiations, this is all, I hate to say it, but learning from other people's mistakes so you don't make the same ones, right? Like, take a look around in your area. I guarantee you there's a provider that signed a bad deal in order to do something quick, right? So there's another guy that signed a capitation contract because he was like, hey man, it's steady money every month. I'm good. I just got to make sure that they're healthy enough to where I don't see them that often, because then my schedule will get buried with just these capitation patients. Right. So then you can go and play with all kinds of stuff. If I'm a specialist that does procedures, then this is where, okay, well, let's make a deal for the procedures and then let's make a deal for the E&M codes, just like basically what Baptist Health did. Right. So
Right. Right.
this is where, again, every business is a slightly different, but the basics are the same. What are my costs? What's my profit margin? What do we want to do? Is this the time that hey, somebody was knocking on our door 6 months ago, maybe we partner with them so we can get a better deal? Maybe that's the conversation that needs to be had. I don't know for everybody individually, but I will say you must change the way that you operate. If the hospitals are forcing themselves to move, you must move. It is
Good
not
point.
too early to make these decisions anymore. You must make these moves now. If you do not, you will close or you will be sold. You'll be bought out in the next 5 years, because it's just, you're going to get tired. You're going to get burnt out. This is where the provider burnout comes into play, because you keep trying to play the same game with the old rules, and the old rules have been thrown out.
To
So, I
your
mean,
to your point, this is more so from an ethics standpoint. You mentioned it earlier. This agreement was, the Medicare Advantage, the My Blue members were affected. It's like cutting off the foot, but keeping the rest of the body. But from an ethics standpoint, I mean, what can you do for those patients that are affected?
well,
I see that. Well, hold on, because I saw in the article Baptist was offering transitional care options to these
yes.
affected patients,
Yeah, so they're
with
offering
some sort of
transitional
ongoing
care. So
in-network
in this
access.
case, yeah, in this case, look at the timing, right? We're in
Yeah,
October 8th right now. So the transitional care is anything that's booked out to October 31st is fine, is going to be covered as if it was in network. It's November
I
1st
see.
that it becomes an issue,
I see.
right?
Yeah,
So what
makes
ends
sense.
up happening is it gives everybody an opportunity, either, okay, either you want to keep this plan and change your provider, or you pay cash, or you change insurance.
So I
So
think
it
the
really
ethics
becomes,
is really, or at least in this case, is they're giving us some
right?
time to figure it out.
Insurances do not contemplate ethics, they contemplate numbers.
Yeah, of course, of
Ethics
course,
does not exist to an insurance company. It's
of
all about
course.
numbers. They're all about actuaries. It's all about underwriting. No one in an insurance carrier, They will give you all the lip service. They will give all of the lip service in the world to Congress. They do not give one shit about the patients, and even less for the providers. Ironic that you need both of those to actually be an insurance company. One person's your client, the other one's doing all the work. Like, what the hell? But that's where we
True.
find ourselves. So what ends up happening, and this is I guarantee you, Ray, if you know anybody at a Baptist Health, call them in 1 month and ask them, hey, how pissed off are your Florida Blue patients that no longer in network? And they'll tell you the patients will freak out
My
because they
cousin,
weren't notified. Or how could I, the provider's office, do this to them, the patient? Because they've been so good to me for the last 4 years, 5 years, whatever that number is, right? And I have to tell them, look, this isn't on me.
yeah,
You have an insurance plan. You made an economic decision. And in this case, Florida Blue made the economic decision with us. The
good
irony is
point.
that back in the day when Major Medical first came out, they only paid in network, and the excuse was because in HMOs they were certifying that people were providing care at a quality standard that met with their professional ethics and
Would you agree
it's all about
that
numbers.
at the end of this, the patient's probably still going to blame the doctor?
Absolutely. The patient's going to blame the doctor.
It's
The
your
patients are
fault.
going to chew out that front desk person.
Oh yeah, yeah.
And
This is how
what's
it
our
is.
defense?
Nothing.
What's our
Wow.
defense? And I don't want to be black pilled on this, right? Like I don't want to be black pilled on this. But this is where you need to come up with an option. Hey, Bobby, here's the option for you. I can't tell you legally what plan to go to, but I can tell you that this plan clearly isn't going to work for you because I like having you here. Do you like coming here?
Right.
Yes. Well, then call up your insurance broker, or if not, go to Google, find yourself an insurance broker, get off that plan.
Yep.
It's that simple. The insurances only react to when they lose money. So,
Good
for
point.
example, Humana just put out a press release yesterday that they are going to be that most of their plans, 94% of their current patients are going to be on plans that lose at least 1 star. And if you're familiar with the Medicare Advantage thing, having 4 stars and 5 stars is crucial to staying in business. Humana has shifted completely to Medicare Advantage. And 94% of their patients are going to be on plans that lose at least 1 star. What? At least 1 star, which means that the network is garbage. And that means the federal government caught up to them and figured out that the product was garbage. Let's be perfectly clear.
Yeah, no, good point.
Well, why when Blue changed? Yeah. So, I mean, this is where, again, do we keep doing this or do we get off the hamster wheel? We got to get off the hamster wheel. If the whale got off the hamster wheel, how are we not able to? If he got his fat together and off the wheel, we need to get off the wheel. It just makes sense. I firmly believe, I don't know about every state, but the Northeast Florida market can absolutely survive on E&M codes, normal office visit codes, 15-minute visit codes with $80. I could almost argue down to 65 depending on the provider, but $80 a visit. You do realize that between 65 and $80 is what the copay is for most people, any bloody ways.
Yeah.
So if you're telling me I can charge, let's go low end, $65 a visit times 4 because it's 15-minute visits. We're looking at 240, 260 an hour in revenue. The only thing I'm paying for is my credit card processing fee.
It's true.
Goodbye,
Take
Cigna
away,
Healthcare Exchange
goodbye
that takes it.
overhead.
Yeah, goodbye, stupid healthcare exchange. Goodbye, billing charges, 8% as a part of the industry average.
Everybody's got to get their
Goodbye,
cut.
exchange
That's
issues
why.
like that.
That's why we're here.
You know, yeah,
Crazy.
goodbye, accounting mess. You know what I mean? Like, but say less. If this is the only money I'm going to guarantee get from my patient any bloody ways, and I'm fighting for $15 extra on this visit with the insurance company,
Crazy.
what are we doing?
Hmm.
Patients will adapt. They understand value. They understand convenience. If they're going to get pissed off, we don't need to stop them from getting angry. We need to guide them to be angry at the correct person. That
Which
is
is not
all.
us. In this
We are
case.
reacting to market forces that are placed upon us.
Yep.
Miss me with the I have a contract with the insurance company when I'm a smaller organization because they'll just make up the rules and change them as they go. Oh, well, by the way, we reduced your rates this year. Why? Well, because I'm the insurance company. What are you going to do about it? Take me to court.
Yeah.
It's
They're
just,
big.
it's just a
It's Big
pound
Brother.
sand.
Yeah.
Pound sand. I'm going to take all your patients anyways.
No, this
Hey, look
was.
at this too. If your patients have PPOs, you can build them, especially if you have VA and things like that. They pay cash. They go and fight the insurance company to get reimbursed.
How does our
Let's that
system,
crap.
Jose, compare to other countries?
Huh?
How does our healthcare system compare to other?
Okay. All right. All right. You really want to touch that one, huh?
Why
Okay.
why would we just
I'm
use
gonna
Europe?
I'm gonna I'm gonna say this, and it probably will be a hot take, but I genuinely believe with all the crap that we are dealing with in the healthcare industry in the United States, we are still the best healthcare industry in the world. And the reason is because while there's a high bureaucratic level of nonsense, it can be diminished by having the private industry stop taking its cues from Medicare. Other countries have more homogenous populations, so they can get away with having a national healthcare system, and it's a little bit easier. But there's not one national healthcare system that does not come with much, much higher taxes, much higher weight for routine things that we take a complete advantage of. Um, Good to know,
I would
Tracy.
imagine.
I mean, I can't tell you how ridiculous Canada is. For example, with something as
Canada,
simple as
yeah.
getting an MRI. There are people that are waiting 6 to 9 months to get an MRI when you can probably call an imaging center in your
Oh,
area
you can
and get
do
an
that
MRI
in the same
tomorrow.
day. Yeah.
Same day or
Same day or
tomorrow.
tomorrow.
Like
Yeah,
it
absolutely.
is wild to me. And the crazy
They're all
part
over the
is
place here.
it, but I mean, this is the problem. If you're going to have a national healthcare system, you have to go through the entire bureaucracy. If the
Mm.
US could handle the VA system properly, I would tell you that, hey, maybe a national healthcare system makes sense. Find me a vet that loves the VA. I'll wait.
Your dad.
No.
I'm just-
Oh my God.
Don't tell him I
No.
said that.
Oh, dude, when he's on in 2 weeks, we can ask him.
I can tell you,
He
my dad is a retired Navy vet. Hates going. Or
The VA is
it's
awful
terrible.
everywhere. And you know what the funny part is, right? The VA has to follow all the same rules that private healthcare organizations have to follow. They are awful
No,
at
he doesn't.
following
He doesn't.
any of
He
the rules.
early on he was going there. He absolutely hated it. He's got insurance. He works for Publix now. He's got insurance through them. One of
No,
those
no, 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 no. Hold
United
on, hold on,
PPO.
hold on. Ray, think about what you just said.
What?
He has health insurance for life through the federal government due to his service.
Yeah, I
He
know.
put life and limb on the line for our country, and the insurance he got is worse
Doesn't
than him going back to work somewhere else in the private sector to get and pay for.
I know. I know. I know. It's that bad. He refuses to go.
The
The
NHS,
providers there are
okay?
terrible, and just everything. Everything is bad.
Well,
And you
let
and
me
you
give you another
have you
example. In England,
yeah.
they have what's called the NHS. They instituted it a while ago, right? I want to say this is the first complete generation that's had NHS their entire life. Um, Now, because of the issues that they have been having with the overburdening of the market, because remember, if you have an NHS that runs the entire ecosystem, whether you're a private company or not, you're basically employed by the state. So your pay is based on the state.
Right.
So you basically have a DMV situation, and it's just like the VA. The NHS is so bad that 5 years ago they started, just before COVID, they started actually offering and allowing private insurances. Sweden, oh my God, the national healthcare system, the nationalized healthcare system, like darling for people. That anybody that's saying, oh, government run healthcare works really well. Look at Sweden, look at Norway, all this crap. Guess what? They were super homogenous as a population, which meant that, yeah, they had about 30 million people in the entire country. They were all from the same background, which meant that they knew how to treat all of the same kinds of illnesses. It wasn't until they had a major migration crisis in the mid 20 teens that all of a sudden their nationalized healthcare system went to shit. And so now they offer privatized health insurance as well to supplement and get you better access that you
It's a
pay
good
for, even
global view.
though, yeah, even though you still have that higher tax anyways to pay for the nationalized health system.
Hmm.
Guys, it all comes back to the same thing. I want access to care. That's what I want. I want access to care, and I want the right to choose. I want the right to choose who I go see and who I have a discussion with. And whatever discussion for my health that occurs should only be between myself and my provider. Pound sand everybody else. I love right to try. I love any situation where, hey, this my doc thinks that something off label might be beneficial for me. Perfect. And you know what, boo boo? If everything on label hasn't worked for me, let's go to the off label, because the definition of insanity is doing things the same way and expecting a different result.
Yep. It's a good point.
Ray, you got me all riled up now. What?
All right, all right. Hell, we could even talk about that, comparing U.S. health to health systems to other countries. That could be a topic one in itself.
We absolutely, I mean, I love that. I love that topic. I can talk about that topic for hours. The
Yeah,
big
that's a
thing
good
for that
deal.
one is that there is no perfect system that has been tried and worked yet. I don't care what anybody says. I believe that the best one is the US. There are issues. I believe the FDA, there are a lot of issues with um, pushing some technology forward. However, pharmaceutical wise, we are the bleeding edge.
Oh
Everything that
yeah.
gets approved in the US pharmaceutically gets pushed out to the rest of the world like this, because the FDA approves it. So once a pharmaceutical company decides, and I'm not necessarily pro pharma, but if they do their job, I'm not anti pharma either. Like I just recognize that it costs a metric crap ton, a
Mhm.
GDP of small countries to get a drug from conception to market.
Oh yeah.
Costs way too much money. And even more so because of how litigious our society is, that no matter what the drug is, you're going to find a lawsuit for it. Just wait. Even though everybody that got one of those mRNA vaccines had to sign a waiver saying that they won't sue because this is EULA, which is a whole nother bag of tricks. You watch, give it 10 years. There's going to be some lawsuits for that. All you need for a lawsuit is someone who feels aggrieved and a lawyer that'll write the paperwork up. That's all you need in this country.
I know. I'm not
Somebody will do it.
disagreeing. I'm not disagreeing.
Somebody will do it real fast. How quickly it gets kicked out of court, that's a whole nother bag of tricks. I have no idea what the result will be. But it's not that hard. It's not that hard. But yeah, so the TLDR, if you wanted to fast forward to the end, Baptist Health pulled a shrewd move. It worked out in some ways, didn't work out in other ways. I think their better part of the deal was that they got rid of the Florida Medicare Advantage plan and the Florida Obamacare exchange plans. I think that's where they're going to make that they're going to make more money by losing those patients than anything else. And that basically also kills those plans in Northeast Florida because who are you going to go to?
Yeah.
You're not going to want to go to Ascension after all the crap that just happened to them. You're not going to want to go to Shands because there's only one hospital in all of Jacksonville for Shands. You know what I mean? Like patients aren't patients are not going to work against themselves.
No.
So it just the chaos opens up opportunity.
Embrace the chaos.
Embrace the chaos, steer into the storm, whatever analogy you want to do, like, hey, you're hydroplaning, don't pump the brake, don't panic, don't pump the gas, just steer into the drift. You know what I mean? Like you just gotta roll with it. So cool. Any questions, concerns, guys? I know Tracy's over here on the other side of the US, but it's nice to hear that she's agreeing with what we're talking about over here. So,
I'm glad you joined us on this one. I'm glad you joined. Tracy, got any other topics you'd like us to talk about? We're booked up for October, but we're looking for some November subjects. And speaking of, next week, we're going to be talking with your dad again. And we're going to be talking about, this was a topic that Don suggested. We finally found it. It was it was on my cheat sheet, scribbled chicken scratch, but we're going to be talking about employee corrective action plans and the termination process and sort of how that plays into compliance.
And I'm gonna say this in regards to that too. This is anytime you're dealing with employees, the argument is going to always be irrelevant of whether you are at a right to work state. It's going to be all about what is in their employee handbook. If you didn't write in their employee handbook that they had to do that, you can't expect them to do that. If you don't have something signed from them saying, hey, this is the job description, then good luck getting that through. When they pull that discrimination card or wrongful termination or whatever crap, judge is going to throw it right out. So, but we'll get deeper into how to do it.
Keep thinking about it. No rush.
But yeah, anybody that's got anything,
I'm looking forward to getting your dad's inputs on that as well.
I mean, he has to deal with it with his major client all the time.
Right.
When you're dealing with an organization that has 350 employees, somebody's always doing something stupid.
He's got to have some good perspective.
You can't put that many people together in one spot and expect everybody to work intelligently. Yeah. Oh yeah, Tracy, we are too here in Florida. It's right to work, but let me tell you, it might as well put in there right to work, but also right to sue. For pick a stupid reason. There was one client that we had that actually got sued because they couldn't bring a patient could not bring their emotional support animal in. You know what their emotional support animal was, Brad? A ferret.
An iguana.
A ferret. Tell me how that ferret is going to stop you from having a seizure. Go ahead, boo-boo.
Anything.
Go ahead.
I'll be a service animal, I guess, here.
Dude, that's a whole nother bag of tricks too, but we'll cover that because that's also part of the employee stuff.
I should find that video. Some guy, and that's like a huge issue in South Florida, these the iguana population. And even so bad as you can literally kill as many as you want. You don't have to.
Oh yeah, they're considered invasive species in South Florida. They're an invasive species.
I've seen some videos on social media. These people just walking them as pets on the sidewalk. I'm like, what in the world? What is going on over there?
I mean,
And then
give
somebody
someone an
commented,
opportunity and they're gonna do something interesting.
so anybody can have anybody can have a service animal of any
So believe it
kind.
or not, okay, so believe it or not,
Sure.
we've got a jet, but
Yeah, yeah.
we can talk about that. But the emotional support animal thing is no more. You have, if you're going to have an animal that is supposed to be a working animal, they have to be trained. You have to be able to provide certification and documentation.
Right.
And so you're not getting away with that crap as easily as you used to about 10, 12 years ago. So
All it
so
took
yeah, I
all
mean,
it took was too many lawsuits.
no, all it took, believe it or not, you know what the final straw was? People were bringing their crazy animals that were untrained in airplanes. And so the airlines
Nobody
started
wants to deal
cracking
with
down
that.
on that stuff, and now a lot of people are as well. So
That's good.
so that's where the legislations come into play. But we'll go over some other time.
Awesome. Well, hey,
We'll get
we
jetting. If you're in the path of the hurricane, stay safe, guys. If
absolutely.
not, then we will see you next week. Ray, I hope your place stays up in one piece. But it looks
Well,
like we're out of the major area of the storm, so we should be all right.
I haven't honestly haven't checked the trajectory. I know we're on the east side of it, so it's not as bad.
Yeah, we're on the northeast side of it. We'll be on the northeast side of the storm, so we'll be fine for the most part. We're in the weaker part of the storm there. It's also gone down in strength, so it only popped up to 5, but it should be hitting. It was originally going to hit
I think
Tampa
it's
at a
supposed to hit
4.
as
Now
a
it's going to
3.
hit. Yeah, now it's going to hit Tampa at a 3, which means that by the time it really comes to the East Coast, it'll be a 1, maybe. So I'm not necessarily concerned about
I'm
it, but
just hoping my trees stay up. That's
we'll see how
all.
it goes, man.
That's all. But all right, Jose. Well, you stay safe. Appreciate you as always,
Yep,
and
yep.
we'll see everybody on next week's episode.
Take it easy, guys.
Take care.
Sunshine.